our, I think my slides are up now. So anyways, thank you for inviting me to present on such a great and critical topic. My role, again, is really large to help set up the following presentation somewhat on the role health centers have increasingly learned to play in the community's disaster preparedness, and why we need to also think more thoroughly about better securing HIT in terms of disaster planning. I won't go too much into the technical details of all the emergency preparedness standards healthcare organizations, and particularly health centers, are expected to hit, since I think Zara's discussion will hit on those very nicely. So I'll just start by providing a brief backdrop on this, and Figula will illustrate for you a successful approach that one health center took. And it was really simple in design, which proved to be amazingly effective, where they took emergency preparedness into consideration when thinking about their own HIT needs. As many of you will know, it's been about a decade since 9/11 and about 8 years or so since the hurricanes hit the Delta. And since then, there's been a major push to maximize preparedness for a range of disasters. And for a long time, much of the community or regional comprehensive response plans have focused on hospital preparedness. And for good reason, since they really are much more equipped and are able to better deal with the major surges in patient volume and trauma. But health centers are now increasingly recognized as key partners that need to be involved, given that they are sole or major sources of care in medically underserved communities. And we know because public housing health center grantees serve nearly 200,000 patients, of whom a third speak a language other than English, need to be part of this disaster preparedness DNA. And so every health center, at the least, should be working through the major fundamentals of preparedness, particularly in regard to assessing their vulnerability to various hazards, and looking to see how they can or should address the following: mitigation, preparedness, response, and recovery. And again, Zara will cover some of this, I think, in a bit more detail from La Maestra's perspective. And of course, as all the HRSA grantees may know, HRSA has been pushing health centers to conduct annually a hazard vulnerability analysis to assess their ability to address events along these lines. And it should not come as a major surprise, I hope, to many of you, that most health centers do actively participate in community or regional emergency planning. And some of this can be attributed to the fact that hospitals' level of preparedness varies significantly because they can't necessarily shoulder the burden of all variety of disasters. So we know partnerships with other organizations, including health centers, are critical for maximizing community preparedness. And here's just a short list of examples where health centers have contributed, including being part of a surveillance systems for emerging diseases, serving as point of distribution for medicines or vaccines, helping to promote awareness and personal emergency planning, providing translation services, as well as providing staffing who can help address mental health needs of trauma victims and so forth. But in reality, the level of health center participation in emergencies tends to be uneven for various reasons. And here's a short list of some of the challenges I think a lot of the health centers can identify with. Some coalitions may not necessarily understand what health centers can really contribute. Health centers themselves may not know what they can contribute or don't know what their role should be. Maybe there's historical distrust among some of the partners. And in some cases, health centers may not feel a major sense of urgency because of other competing priorities. And of course, there's a cost or a budget issue. For many health centers already operating at the margin or with relatively little staff, it's even more daunting to add to the work they are already struggling to do, basically addressing the primary health care needs of their patients. But I don't want to leave you with the sense that this is where health centers are at, that few have accomplished much and done anything about it. On the contrary, health center preparedness continues to evolve and improve. More and more health centers are engaging at some level with city, state, and regional planning, getting more training and technical assistance, assessing their own capabilities so that they can think about what they bring to the table. The National Association of Community Health Centers, HRSA, and other organizations are providing more guidances and training to help promote what type of activities health centers can and should be in. And of course, also promoting personal preparedness and helping to enhance that kind of thinking. And obviously, the North American Management, as you're all listening to, is another organization that's contributing to this effort. And because of this, more health centers are increasingly getting better at engaging with their partners. And in some circumstances, even thinking about what they can purchase together, for example, to minimize costs for any single facility, and even thinking about leveraging their community HIE or REO systems. And nowadays, budget and program planning increasingly look to data recovery as well. The number of organizations and businesses offering data warehousing capabilities, for example, is increasingly growing, and the number of health centers storing their data in those places and elsewhere is also increasing. Yeah, I won't dwell on this slide long since others can cover this, but just quickly, what we know is that health centers don't really need to be a major player in all these efforts in these coalitions, but they should recognize that they have an essential role to play given the area and population they serve. And given the need to triage and transport patients, HIT is increasingly seen as a critical tool for doing some of that, and should be thinking about much more about how to effectively secure their data so that they can readily access it during and after an event. In fact, HRSA does expect health centers to prepare in the event of a disaster. Their ability to access patient records remotely and quickly. And here, specifically, they expect health centers to have a backup information technology system in place, and that at least they think about off-site storage. But definitely where risk of a disaster is relatively high, they do encourage health centers should move on securing electronic records that effectively allows for timely retrieval of patient records so that they're able to maintain some level of continuity of care. But HRSA's guidance still remains rather broad and leaves health centers to find their own way in terms of being able to timely recover data so that their patients can, again, maintain that level of continuity. So the tendency is that health centers largely store their data where they know other health centers are storing them. But it's not clear how well those systems would actually work for each individual health center, especially when there's a large-scale issue. And there are significant demands potentially on a particular system or data warehouse. And this issue stems from the fact that while HRSA is a growing tool for better preparing health systems, it is seen largely as a medical tool for transmitting information from one practice to another. So thinking about data recovery isn't as high a priority or isn't necessarily on their plate. And what gets lost is thinking more thoroughly about how often to back up and upgrade their systems, how physically secure the data may be, how much redundancy is built in, particularly in cases of hardware or power failure, or identifying appropriate hardware and software with a trusted and experienced vendor who really understands your practice, your current and potentially projected volume of patients, your potential growth strategy, the number of sites you're planning to operate or currently operate, how often your providers might have to move between those sites, how data may need to be captured, particularly from if you have a mobile van. And like any major business decision, it's not a quick and easy process. And so this kind of approach and investment generally needs to start with leadership of your organization and acknowledging the need to incorporate your recovery strategy as part of your HIT strategy. And so in the case study that you will hear next from Fegula, I think will hopefully illustrate these points much more concretely. So let me turn this over to Fegula.
Hello, good afternoon, everybody.
Ms. Jacobs, you should now have control of it.
Yes, but I have lost the slides, Damon. There we go. Okay. So perhaps you could just advance the presentation because my slides follow Dr. Shin's. Okay. Good afternoon, everybody, and I want to thank you for inviting me to join you today to talk about this very important set of issues around disaster preparedness. So what I'm going to do is talk about a particular example of a health center that was extraordinarily fortunate in terms of being able to come through a disaster to the benefit not only immediately of their patients, but of the surrounding community, and tell you a little bit about how they did that and what some of the lessons were out of that experience. So as I think everybody knows, approximately a year and a half ago, in May of 2011, a Cat 5 tornado, which is a tornado that has winds of at least 200 miles per hour, hit the Joplin area of Missouri. And it was an absolutely catastrophic storm. It destroyed and damaged thousands of buildings and homes over a distance of about 17 to 20 miles and a full 3/4 mile area in Joplin, Missouri. And it resulted in an estimated 162 deaths. I see that there's a typo on the slide, and hundreds, if not thousands, ultimately, of non-fatal issues. It was truly a devastating storm, and part of what happened was that it destroyed the largest physician complex in Joplin, the Regional Community Health Center, and many of the physician and dental offices that were in a corridor, as is typical, near the regional community hospitals and other providers. As a result of the devastation, the U.S. Department of Health and Human Services declared the area to be a public disaster, and staff were dispatched from the National Disaster Medical System, which some of us know as NDMS, to help assess the damage that had occurred and to begin a plan of immediate assistance and a recovery planning process. Next slide, please. Devon, I'm sorry, I cannot seem to advance the slide, so thank you. So the provider that was in the midst of all of this, the FQHC provider, was Access Family Care, using here on the slide the acronym AFC, which is a federally qualified community health center that had been in existence since the mid-1990s. It was originally founded as an organization called Ozark Tri-County Healthcare, and later grew quite significantly, was qualified as a community health center by the Bureau, and now serves the communities of southwest Missouri, including the Joplin area. AFC operates 4 sites, with 2 of them that were located in the city of Joplin, and they serve approximately 15,000 patients annually. They provide a full range of comprehensive primary care, medical specialty, and dental care for both adults and children, and approximately 98% of the center's patients are low-income patients who have incomes at or below 200% of the federal poverty level. Approximately 46% have coverage through Medicaid, and another 40% are uninsured. So we're talking about an area that sits in and around a small city that is serving a population that faces a lot of disparities. And of course, when the storm hit, the potential for greater disparity was underway. So the tornado wiped out, as I mentioned earlier, other providers in the community, but AFC was extremely fortunate in that while their smallest site was destroyed, this was a small site that provided behavioral health care and primary care as a satellite site. Their other sites were not destroyed. So they remained physically intact in the physical premises at 3 out of their 4 locations. And as you speak with the staff and the leadership at AFC, what they will tell you, and I think that we all know this and we'll circle back to this, is part of that was just pure sheer luck. But the good news about that luck is that it meant that they were still able, once some of the initial issues and problems were cleared, to provide care for their patients. And ultimately, AFC provided a very essential role in the community. They provided continuity not only for their registered patients across all of their sites, but they were also able to support support community emergency relief efforts, and they were able to assist patients whose care was generally provided by other providers than AFC, with, for example, getting emergency services and particularly emergency pharmacy services. Next slide, please. Okay. Well, how were they able to do that? A lot of this has to do with the planning that AFC did around health information technology. And again, I will keep coming back to luck, but there's good planning that helps in every situation. And AFC, several years ago, began planning for the transition from paper to electronic medical records. And they went through a very thoughtful, guided process around this. They knew that they wanted to put in place a system that was accessible for mobile applications, for mobile use as well as fixed use. They really wanted to be sure that they would have minimal disruption to their system. They had some specific expectations concerning the operational platform and security. They had providers who worked between sites and across sites, and of course who had hospital service, and they wanted to be sure that they put in place a solution that permitted their providers secure access from remote locations. And additionally, they were quite aware, even though not all of these various mobile devices were existing at the time, that use of mobile devices and iPads was becoming more important and more important in terms of how providers access to their applications, and they wanted to be able to plan for that. So they set out with that set of criteria to look for ways to optimize their efficiency and to find a platform that would meet those needs. Next slide, please. And ultimately, what they determined to do after reviewing and evaluating a number of different options was to select a local IT consulting firm that happened to be based in Joplin, and we'll come back to that, again too, that locational issue, that offered a hosted solution, including a virtual desktop environment to assist them with the HIT selection and implementation process. Neotech hosts and maintains core applications in an off-site data center. And in terms of the vendors that were selected, the health center went through a planning process to select an EMR and dental record system. Neotech assisted them with that assessment process as well as with the adoption process from really the inception of the planning. And ultimately, Neotech was engaged to host on behalf of the center those core systems and applications and to maintain them in a secure off-site location. So let's stop there for a minute because that's great, but now we've added another link to the chain, and what that means is that the ability for the center to function smoothly either in the day-to-day or in the event of some extraordinary circumstances is going to depend not only on its internal capacity and not only on its infrastructure, but also on that of its key HIT partner. So you have to make sure that your partner has the core capability that you need. Next slide, please. Now, as I mentioned earlier, Neotech is a local provider, and their hosting capability had actually been tested previously. Their facilities are located not too far from the health center in Joplin, and they had actually sustained a fire approximately a year before the tornado that originated in a restaurant nearby their facility. And so their physical facility had been compromised by the fire, but they were able to successfully relocate their data center to a temporary location, and within 48 hours they were back up and running. And during that fire situation, no data was lost, and the health center was able to retain their full data access the following day. So as a result of that fire, Neotech rebuilt their hosting facility. You don't necessarily want to get tested by a natural disaster or a man-made disaster, but sometimes that happens and you deal with it. In Neotech's case, they rebuilt their hosting facility and they made some very substantial structural improvements to their data center. However, disaster sometimes strikes more than once. And of course, when the tornado came roaring through, and as I mentioned earlier, cut through a huge swath of the community, their building that their data center is in was actually largely destroyed. However, the north section of the building, which they had reinforced to accommodate the data center, quite miraculously withstood the storm. And so as a result, they did not lose data despite the destruction of the premises, despite the massive losses to the surrounding property. Neotech's hosting capability did not go down. What they did was very quickly assess the damage, and as the CEO and executive director of Access told me, of course the first concern of everybody was for the safety and security of their staff, their patients, their families. And so the very first thing that happened on Sunday was everybody checking up on those they worked with to make sure that people were safe and were secure. Once that was done, and once they helped some people whose situations were fairly dire at least find some immediate temporary relief, they began to deal with the institutional problems that they were facing. And so in Neotech's case, what they did after taking stock was to relocate temporary quarters to make sure that client service wouldn't be disrupted, because as sometimes happens in the aftermath of a disaster, there are after effects, and they didn't want services to be disrupted. And they were able to fully resume their operations within just 12 hours. And this proved really essential for the health center as well as for the larger community. So as I mentioned, the storm happened on a Sunday. Within just a day or two, the center was able to open following the storm, and they became the focal service delivery point, not only for their own patients, but also the emergency access point for others in the community. Because let's not forget that the hospital was devastated, and some of the other providers were devastated as well. Neotech helped the center establish its on-site intranet. However, there was a loss of internet in the local area, and that lasted just about a week, which meant that there was no connection to external resources. But there was the on-site intranet available, and as a result, the health center was able to get its own operations up and running. And one thing that I do want to mention here is that AFC has very much credited not only Neotech and their own staff, but they also noted that the city and the county had performed very effectively with respect to emergency preparedness and response activities, and they were busy clearing roads and trying to restore power, and also, of course, they were getting support from our national organizations. But again, because the other providers were so adversely affected, they became really an essential link in the chain of response and recovery, and we're really grateful for the support that they did get. Next slide, please. Okay, so imagine being in this real-life disaster scenario. And the question is, again, putting luck aside, we now have a situation where the health center did withstand the physical effects of the storm, and they did have a data provider and a hosting provider that helped them withstand the devastation. And so clearly their good planning and their vendor relationship was helpful, but one of the questions is, well, what was the cost of doing this, and was this a cost that was reasonable or sustainable? And in trying to understand this from the health center perspective, what they explained to us was that they felt that the return on investment for both the adoption of their EHR and their secure off-site hosting was really invaluable. In terms of dollars, they have reported to us that they've spent approximately 4% of the center's operating budget on the acquisition and installation of the EMR, and allocated approximately an additional 1% for the initial implementation and support of the EMR adoption. After running the EMR for a little while, they determined that there were a few key features that they were lacking, and subsequently those were added. Those included, by the way, e-prescribing, which again became something that was very helpful in this disaster, as well as document scanning. Again, another very helpful feature that were added. As well as some third-party connections for their lab connection. And then 2 years after the initial installation, they did add additional EMR licenses to better support their providers and their teams. But the operating budget grew, the center grew, and so the proportion of the center's operating budget that is dedicated to their annual EMR licensing as well as their support remains about 1%. They also budgeted 1% for off-site hosting as well as EDI services and e-prescribing at about 0.5, 0.6 of the total budget. So in terms of real dollars or percentage of budget, it's a fairly nominal percentage of their operating budget, but what they got was enormous value that allowed the center to effectively manage care across multiple sites and improve their efficiency in the day-to-day, as well as find a partner, in their case in Neotech, that was able to help them in this situation. Now you may be wondering, well, what happened to Neotech? As I mentioned to you, that their facility was largely destroyed. They ultimately determined that they were not, after the fire and then the hurricane, that they were not going to rebuild an independent hosting facility and ultimately move to a secure level 3 colo with even greater physical resistance than they had, and also considerable expansion capacity, because you can bet that demand for the services that they were able to provide was really understood and known. Next slide, please. So what do we conclude? Well, here, operational capacity, the ability of the health center to withstand this situation, depended on a couple of things. It depended on their internal planning, it depended on their internal capacity, it depended on infrastructure. In their case, it depended on their partners. It also depended on luck. But at the end of the day, they came through this situation swimmingly. Some of you may have seen heartbreaking photographs from Joplin in the days following the storm. And of course, when you see that kind of devastation, even from afar, and you understand how people's lives are affected, it truly is devastating. One of the worst photographs, though, that I saw was one that might not have been widely circulated. It didn't relate to loss of life or loss of property, but it was a photograph that showed paper records from another institution that had literally been blown into the air and landed many, many miles away, and the aftermath of trying to deal with unsecured paper and kind of old legacy paper systems. So, so in conclusion, what I think we learned from Access is planning, partnership are essential, but that the costs that were incurred are manageable, and that in the wake of disaster, as we look at these in hindsight, clearly this is money well spent. What is probably going to be enormously helpful to others as we go forward is that federal investment in to help support health information technology has really been essential to health centers, and continued investment, of course, is essential. AFC was able to get back on the ground quickly because they had had substantial support from the Bureau and other organizations to adopt IT in the first place. But what really is needed going forward is some clear guidance around planning for and overcoming disaster scenarios. Some alternatives based on industry standards with respect to how you assess data security, data backup, redundancy planning, and help with the development of effective strategies. Data security needs to be identified as a key priority, we believe, for funding support. And today we have a lot of support for acquisition and implementation, and clearly for quality, but perhaps less support for both evaluating and implementing optimal data or hosting solutions. And clearly, as we read of and learn of and potentially experience more disaster scenarios, what this experience demonstrates is that investment is essential, external support is essential, and that collaboration with our grantors and funding providers to have the best possible preparation will at least help position you effectively in the event that you are lucky enough to sustain, the kinds of horrific scenario that AFC did sustain. So again, I want to thank you for having me, and I'm going to now turn this over to our next speaker.
Ms. Zara, you now have the mic and control of the computer.
Okay. Show my screen. Okay, this is Zara, and I'm trying to get the, okay, here it is, I think. Oh, here we go. Great. Does everybody see the screen now? Okay, I'm giving a presentation here from La Maestra Community Health Centers. I'm the CEO, and I wanted to basically share our experiences with the blackout that happened here in 2011. It was about 36 hours. And also the California wildfires of 2003-2007 and what that taught us. And what we are now trying to put together and add on for emergency preparedness in the community. What these disasters kind of showed us was that, we had been, like other community health centers, passive in terms of having, having a plan, participating with the emergency preparedness, the statewide effort, as well as the Council of Community Clinics, our consortia, and also the California Primary Care Association, as well as the county. Despite all of that, we still were, I think, passive, because when something actually did happen, we saw that there were still so many pieces missing. Next slide, please. Or here. Where did it go? Push it back. How do you get forward? How did you do that? Okay. Okay.
Sorry,
Are you?
I'm in control.
Oh, you're in control.
Oh, okay. I'm in control? Oh, okay. You're in control. Good. So this is some of the list kind of that our team put together from, the basic needs perspective, and, what was being passive and what was being active for us to then move forward on. This, of course, doesn't include, our whole EHR and our, developing a whole other IT redundant site and so forth. That was, that's ongoing as well. But the community, I mean, just looking at it from our clinic perspective, for example, we had flashlights in every unit, department of the clinic, and then when the emergency happened, I mean, nobody could find them because they had all left. We have now a big basement, new building, and we should be having in there like a crash cart specifically for, disasters, emergencies, so forth, water supplies and the like. We also found that through these disasters that a lot of the community that we work with, and we're actually in 6 different clinic sites throughout the county and schools as well. What we found is that the people that come to us for services, they don't, most of them don't speak English, or they do not speak it fluently. And even if they do, they want to come here to get reassurance, or they're, very anxious. And, those that have chronic diseases, they need, inhalers and so forth. I mean, we found that in the 2 fires. A lot of the ash was over the city. People found it hard to breathe. People that didn't know if they were just having an allergy or, they were developing asthma. We needed those masks that all of a sudden we found out that we couldn't use the regular masks for that we had in the clinic. We had to get those that were N95 that were, like certified, fit tested, and yeah, you had to fit test it to everybody, the workers, and they recommended, like, we changed these masks, so what was it, like 5 times a day or something, and the cost was just prohibitive. So, I mean, that's something that totally came out of the blue. We didn't know about, the fit testing and, where we're going to get these masks, to have extra inhalers on site, the fact that people that have already mental health issues are going to, just really be needing reassurance and some counseling. Our sites that have over 20 languages, different populations that want to access not only care, but they want to know what's going on, because these folks have obviously been from very traumatic backgrounds, and that's, they'd gone through war and things like that, and they just didn't know what was going on. Also with the blackout, things like, I could say here on the passive list, when the company installed our elevators with our new building 2 years ago, yes, they put us through the training, this and that, what to do, but when the emergency actually happened and there was no power, we were all running around between the floors trying to yell through the elevators to make sure nobody was stuck. And then finding out that, later on we were supposed to go down to the basement, and which we eventually did, and the elevators just drop down all the way to the bottom floor, and then they open up and then they don't work. So at least people can get out. Well, we didn't know that. Next slide, please. Bottom line, who do we rely on? Ourselves, number one. And that's why we're trying to build up as much resources as we can within our, clinic sites, like that crash cart or stockpile of medications. And that, of course, costs money, just like it costs to get a generator at each one of our sites. We have to do that. I mean, the last, another important lesson that we learned, we have a generator that's pretty powerful here at our main site, main headquarters in City Heights, which you can see the picture of. This is the building we built 2 years ago, after 21 years. And it's got solar panels and stuff on the roof, and this generator is powered by, the solar on the roof. And what we did was we had to bring all of our vaccines from our other sites over to this main site because this is the one that had the generator. Well, getting the vaccines from our other sites, we had to get the ice, from the local liquor store, which of course was willing to work for us and give us a good break at like $20 a bag of ice. So that was another interesting thing. And so getting it over, making sure that those vaccines were not compromised, that was an issue. Well, then still there wasn't enough power to run the other areas of the clinic. So now we've gotten to make sure that the emergency lighting is working, and we have drills, not just the regular drills that we're required to do, like the fire drills and the code blues and things like that, but actually emergency preparedness drills, which is different, and that's one thing that we've learned as well. Next slide, please. What, the arrow? They did it. Okay, so now this is one of the big lessons that that we did want to share, is that clinics, community health centers in the community have to always check and make sure, first of all, put enough aside budget-wise, try to get grants, which we're still working on, to make sure we have generators at every site, make sure we check those generators, where's the fuel cap, where's that crash cart or emergency cart kept that has, the stockpile of the medications, the general antibiotics and, burn creams and, all kinds of things that, that one would need, as well as the water, and then have somebody assigned that checks that, the expiration dates, replaces, keeps that up to date. Otherwise, there's not going to be anything here. We've already seen that about, who else we can rely on. The company, for example, with the elevators, they said that they were 12 hours, that's the soonest that they could come over to look at our elevators, because they had hospitals that they were going to with people stuck inside the elevators here in San Diego. And we said, well, we didn't think there was anybody in our elevators, but we definitely wanted to check that out. And then for example, the mapping, the software mapping that we've all had drills on, and we have been collaborating, we community clinics and hospitals and first responders, the police and the fire department and the local schools and everything, they have been on this software that's called Web EOC, and the two-way radios, and there's a whole radio system and everything connected that's supposed to be up and going when there's an emergency, so we can all tap in and see what's going on. It tells you what you're supposed to do, where the shelters are that they're setting up, like if it's at Qualcomm Stadium or wherever. And this last one with the power outage, of course, there was nothing, nothing at all. And obviously it had something to do with the lack of electricity, but still the radios could have been working, and they could have told us, what was going on, or what we could expect, or where to send people if, for example, they needed electricity, or they had chronic diseases, or they were, they needed more of an intensive level of care aside from the hospitals. Next slide, please. Okay, so again, this is where the generators definitely have to come in. We went down the street here to see if we could store some of our vaccines at a local children's hospital. They have kind of an off-site urgent care that's a part-time operation. So we thought, well, gee, they definitely should be having a refrigerator there that we could put some of our vaccines in. We went over there, and they said, oh, no, when the power shut down, their refrigerator locked itself up, so they couldn't open it at all. And so they obviously are working on their disaster plan, too. But we saw, these bigger generators that there was a building next to us at the time being constructed, and their construction team had a huge generator, and we asked if we could plug into that. They said, yeah, but we don't have any fuel. So that's another huge thing is, okay, how to store this fuel, how to have access to it in time of emergency, and then again, not follow the lesson we learned with the ice, which is, they're going to sell it to you for how much a gallon. That's the issue in transporting it and getting it, yeah, gouging for sure. Next slide, please. And then we do have drills where we'll say, okay, certain staff have volunteered to be on the disaster preparedness team, somebody from PEDS, somebody from family practice, and they'll all, participate in the drills depending on, what the mock scenario is. But again, when this is really real, it's a whole different story, and it just super made clear to us how far behind we are in terms of being really prepared, and not only for ourselves but for the community, and that's our responsibility. I know that when the first fire happened in 2003, it was just a super big surprise for a lot of the health centers, including us, and 2 of the health centers basically just closed down. And they said that that their attorneys had told them that they should not be open because they weren't prepared to take care of the community in an emergency, and so they didn't want to mislead their patients or something. And obviously that's not what it's all about. It's about being a community-based organization and being responsive to the clients, the patients that that the health center serves. So I think that as far as we're concerned, we're here and we're open. The power of communication is huge. Again, the two-way radios were absolutely the best. And obviously the systems, if you can get a system with the right people, partners involved, and it's monitored all the time, a software system like the one that we mentioned, Web EOC, that the county uses and everything. Next slide, please. This is something that is very true. Again, being passive, having a passive plan is very different. We don't have experience or regular experience, so we're not very competent at responding to emergencies. So again, this has to be something that we are working in with our drills, ongoing basis. This is not just a plan to have and put on the shelf. It's a manual. It's got to be something that we actively continue to develop. Totally. Okay, next slide. Okay, our security played a huge role in this, in securing our sites at all of our sites, because they were the ones with the radios, and also securing the facility. You can imagine no power, no alarms, and no cameras, and so our security folks basically became, like the captains at each site. The other thing that we've learned is we just got a mobile van, a mobile clinic that we have been using at the schools and out in the community. We're going to work our plan into we're going to be incorporating our mobile clinic into our emergency preparedness plan to see how we can deploy this vehicle in emergency situations. I think that's going to be huge. Next slide. How many minutes do I have left? Okay, here we talked about the security. That's great. Also, their proficiency at getting a hold of each other, getting a hold of the head of the security team, and being able to, you know, do this in a calm manner, because again, that's where people are going to flock to is an area or, you know, medical home in the community. Next slide. And yeah, that health centers definitely are diverse organizations. We serve diverse cultures, and that is super, super important to make sure that the same promotoras, the same community workers, health coaches, whatever you want to call them, get the message, and they know then how to give the right message out to their population, to their culture, to then, you know, reassure them and be able to refer them to where they need to be served, or what area in the clinic they need to go to. Next slide, please. The other thing we were told during the fire, one of the fires, was that the county wanted us to provide like a isolation room. And that was very hard for us at the time, would be now too, but to have them, like people that might be contagious with something, you know, where would we put them? And it never worked out, obviously, and we didn't have the need for it, thank God. But I think this was when they were going with the bird flu, you know, the bird flu epidemic and so forth. They wanted us all the health centers to secure a separate space, and that's something, again, that, you know, that would be very difficult. Maybe now in this new building we could, but at each one of our sites would be very difficult to do that, and continue to provide them with the same level of care. Please do the next slide. So these are just some of the benefits from taking the initiative and putting that extra effort in developing a network of responders and going through the practice drills and actually, you know, paying attention to keep incorporating this plan all the time. You know, keep it developing. Next slide. These are some of the partners that, you know, that we've been working with for years here, and again, you know, in the end, we're on our own. That's kind of what we've seen until like day 2, day 3. Next slide, please. That's it. Okay, I'm done. Thank you.
Thank you so much. I would like to first of all thank all of our panelists. I think we learned some really, really great information today, and I know it is useful to those of you, your FQHCs, who were trying to figure out what kind of emergency things you need to think of as you're taking care of emergency preparedness. If you would like to ask the presenter a question, please submit it through the question box on your control panel. We have about 2 minutes. And if you are dialed in through your telephone and would like to verbally ask the presenter a question, please use the raise your hand icon on your control panel and your line will be unmuted. Devin, can you tell if we have any questions at this time in the queue?
No questions at the moment.
Okay. I do have one question that was asked, and I can ask all of the presenters. Has any of you used social media of any kind in terms of getting the communications out on how the health centers can be used if anything happened during this disaster period?
This is Zara. We can answer something on that.
Okay, great. Thank you.
Yeah, in the case of like the fires, we can definitely use the apps that are like the app that's on your iPhone. What is that app called? San Diego County Emergency, and that's our app that we can use. But in the case of the blackout, I mean, all the phones were down, even the cell phones. There was nothing. And so it's just a manner, communicating within the staff, and then the staff can communicate, like through these two-way radios with the populations that they're serving. Thank you.
So I'm happy to jump in here. This is Fagala. I think the important thing is that, because you never know what systems are going to be affected by the particular scenario that you actually live through, having some redundant capability makes a lot of sense. So as Zara was describing, they had no phone service. But in other cases, and I'm familiar with with work we've done with other providers where they have had phone service or at least texting capability, but no email, for example. That's been something that's been very, very effective for them. And so I guess that what I would say is plan for, especially these days, the use of maybe more non-traditional media, social media, because that might be an option that's available. It won't necessarily be, and it might in fact be the only option that's available. So for example, in places where television and radio have gone down, but phone capability and data transmission via text over the phone has not gone down, that's proved to be a useful backup.
Wow. Thank you very, very much. I think that is excellent advice. We have now come to the end of our webinar. It is at 2 o'clock, and what we would like to ask, if anyone has any further questions, that you please email us. Contact us here at the National Center for Health and Public Housing or North American Management, and we will contact actually our guest speakers as well and forward your requests or your inquiries that way. So again, we want to thank all of you for joining. We would like to especially thank Dr. Peter Shin, Figela Jacobs, and Zara Marselian for presenting on today's webinar. This has been a wonderful topic with great best practices and lessons learned, and I think for many of our FQHCs, as we continue to provide training and technical assistance, I think this gives them a great idea of how to incorporate effective emergency preparedness planning at their sites in terms of in times of disasters. So thank you all for joining us today. The webinar will be archived and available on the website following this webinar. Thank you, everyone.